Let's start with just some terminology. You can read along as well as I can, but nocturia is basically the number of times that you get up to urinate, and it's pretty specific. It has to be, you have to go to bed first. It can't be the last pee of the night, like when you get up. And then there's also a finding, which is specifically the number of times that you get up, and it's derived from bladder diarrhea. We'll talk more about that in a second. A key part of the whole nocturia concept is this idea of nocturnal polyuria, which is technically a sign, but it's an excessive production of urine during an individual's main sleep period. And there's a few ways that people try to quantify that. I've just listed a couple here. The most common one is nocturnal polyuria index. And so you take how much urine a patient makes at night and you divide it by how much of that is their full 24-hour urine, and you get a percentage, and that will depend on whether they have nocturnal polyuria or not. There are age dependent or differences by age. You can see 33% if you're over 65, greater than 20% if you're younger, and then there's this gray sort of middle age, 20 to 33%. There's also something called the Nocturia Index, which I don't use very often, but it has to do with how much you void versus the amount that you void during the day, and it can be greater than 1 or greater than 1.5. But the classic number that you will hear, if you ever to see it on a test, is 33%. If you make more than a third of your urine at night, nocturnal polyuria. It's also worth just mentioning enuresis and nocturnal enuresis, which is bedwetting, and that's incontinence that happens when you're asleep. It's a little bit different than nocturia, and it has a larger range of things that I'm not going to get into as to what could cause it. But basically, it's when patients will describe, well, I woke up and I was wet. I didn't get the signal to wake up, and it's very different than if you wake up and then you go and you can't make it to the bathroom and you have incontinence. And so the way you assess that is, does the leakage occur while you're asleep and unaware of it, or did you get woken up and then leak? And so that can be helpful as well. We all saw that in this room, a lot of people get up once at night. It is really common to get up. For most people who are in their 20s to 40s, you can see people get up about one time a night. As you get older, you get up more often. It's more common in men. I don't know how they calculate costs, but it's a costly condition, as you can see there. And that figure just shows that as you get older, the prevalence of nocturia gets worse. And it can be bothersome. Most people get up one time, they go back to bed, it's not a big deal. But by the time you start to get up twice or three times, the bother is significant. And we have all seen patients that come in and they are like, I get up every hour. It is a real bother. But it's also worth knowing that it's around 2 to 3 times per night that the bother really kicks in. But it's more than a bother, right? So here's the thing about nocturia. Now this is sort of a crazy slide and figure, and I know it's kind of weird, but basically takes men on top and women in the bottom, and their scales go away from the middle. And this just shows the impact that nocturia and the number of times that you get up at night impact various aspects of quality of life that you can kind of see at the bottom if you squint. But across every domain, it can have, particularly if you get up 3 times a night or more, significant impacts. And for men and women, it's about the same. There aren't that many differences, except all the way on the far right. Sexual activity, interestingly, is a bigger issue for men than it is for women, but otherwise, they pretty much parallel across the board. But more than quality of life, it is associated with depression. Falls are a big problem. So you can see the relative risk of 1.3 for nocturia greater than 3. Direct relationship to mortality, and there are these vicious cycles, right? So sleep deprivation leads to daytime fatigue, loss of concentration, cognitive impairment, and can have impact on underlying disease. So, for example, this graph kind of shows that. So, and I'm going to talk about more of the causes of nocturia in a second, but you can see nocturia in that purple box on the right. It's caused by a number of different things: hypertension, sleep apnea, impaired glucose metabolism, AVP, but then it causes poor sleep, which then causes those things as well. And so nocturia can have a direct increased effect on mortality, as can all these other conditions. And so it's a vicious it's a piece in this vicious cycle. So what causes it? Well, you can really break it down into 3 different boxes of pathophysiology. You can have low volume bladder voiding. You can have increased volume of nighttime urine output. And then you can have sleep disturbances, which can factor into both of those things. And if you look at the mechanism, like I just talked about, in the various conditions, you can kind of see there in this graph or this table that things that cause small bladder voids are things like overactive bladder, BPH or bladder outlet obstruction, urinary tract infection, anything that's going to cause a low bladder capacity. I would include an increased post-void residual urine in here too. Increased urine production at night. We briefly talked about nocturnal polyuria, peripheral edema, congestive heart failure, diabetes, drinking too much during the day, diuretics, and then sleep-related disorders. Sleep apnea is a big one. Anything else that disturbs the sleep. And then hypertension has an unknown mechanism, but also has a direct impact on nocturia. All right, so the way the nocturnal polyuria works, again, I told you about the index, that if you measure the urine made during the day and how much is made during the night, and remember 33% is that important figure, but it's typically caused by a decrease in arginine vasopressin, which, if you think back to all those physiology classes, I'm going to give you the 30-second review so you remember. Vasopressin is produced by the posterior pituitary. It is produced in responses to low blood pressure, low volume. So, I mean, classically, you think about some kind of trauma and people are bleeding, their vasopressin goes up. But it acts in 2 areas. It can act in the kidney on the vasopressin 2 receptor. It can also act on the blood vessels and cause vasoconstriction that drives your blood pressure up. But in the kidney, it will bind to these vasopressin 2 receptors, and that causes translocation of the aquaporin channels that goes to the collecting duct, and that promotes the resorption of water from the kidneys, so you make less urine, and it increases the concentration of your urine. And what's interesting is that in most people, in younger people, there is a variation in how much AVP is secreted, and normally there is a spike during our sleep hours. And so on the left, you can see these are serum measurements of AVP in young people. You have to just imagine the time of day over on that scale. But basically, between about 11 and 6 or 8 in the morning, AVP is high. So we're concentrating our urine by reabsorbing water, so we're making less urine. But when you measure this in elderly patients or just older patients, 60 to 75, this whole thing is blunted. So they are not concentrating their urine at night. They are making more urine, and that's going to drive the nocturia as well.